Hi, we are here with Dr. Guru Sonpavde, who is the bladder cancer director at Dana-Farber Cancer Institute. He'll be talking with us about some of the top bladder cancer abstracts being presented at this year's symposium. Hi, Dr. Sonpavde. Thank you so much for being here today.
Thank you.
Great. So, you are actually chairing one of the rapid abstract sessions this year for urothelial carcinoma. So, what are some of the studies that we're going to be hearing about this year in that session? What are you really excited about?
There's one study that I really want to highlight, which is the study that looked at the combination of enfortumab vedotin and pembrolizumab as first-line treatment in metastatic urothelial carcinoma. And these were patients who were not cisplatin eligible. So this was a small study, modest-sized, non-randomized study of around 45 patients. And the exciting thing about this study was the high response rate. The response rate was like 73%, including close to a 15% complete response rate. And the responses were seen regardless of PD-L1 status in the tumor. So this was a really highly promising regimen, in my opinion. The toxicity profile was manageable also, and as expected, and nothing prohibitive was seen. So I'm very excited about the potential for this antibody-drug conjugate enfortumab vedotin in combination with pembrolizumab.
Definitely. Now, there's also the BLAST-1 trial, which is looking at nivolumab, gemcitabine, and cisplatin in patients with muscle-invasive bladder cancer who are undergoing cystectomy. So could you kind of give a little bit of overview of that trial and why it's important?
Right. So this is a study in which I was involved. This was a non-randomized phase 2 trial that combined the standard chemotherapy of cisplatin plus gemcitabine in cisplatin-eligible patients as neoadjuvant therapy for muscle-invasive bladder cancer, and combined nivolumab, the PD-1 inhibitor, with gemcitabine cisplatin. Again, this study was a modest-sized phase 2 study in about 41 evaluable patients, and the exciting thing was that around 65% of patients achieved less than muscle-invasive disease, non-muscle invasive or complete pathologic complete remission with GemCis plus nivolumab. So this is again an exciting combination of a checkpoint inhibitor, nivolumab, plus cisplatin-based chemotherapy. And also I would add that a phase 3 trial is ongoing to validate these data to see if this combination not only increases the pathologic complete remissions, but improves the progression-free survival and overall survival of these patients. So that's the phase 3 trial called Energize that's going on.
Very wonderful. Thank you so much for sharing that.
Thank you.
So now you're also a co-author on the Proof 302 trial, and that's looking at infigratinib in upper tract urothelial cancer. So can you talk a little bit about that trial?
Right. So the Proof 302 trial is a phase 3 trial looking at adjuvant infigratinib. That's a potent pan-FGFR inhibitor, oral tyrosine kinase inhibitor. This trial is looking at adjuvant post-operative infigratinib for 1 year in patients as in the adjuvant setting for not only upper tract but bladder, although it's weighted towards upper tract. Bladder, muscle-invasive bladder patients are also included. And these patients could be either post-neoadjuvant chemotherapy, or they can be without neoadjuvant chemotherapy but cisplatin ineligible. And they need to have the FGFR3 genomic alteration in the tumor to qualify for the study. So this is an exciting study because we don't have anything in this molecularly selected patient population in the second line in the adjuvant space. Of course, as you know, erdafitinib is an FGFR inhibitor approved in the post-platinum metastatic disease setting. So this gives us hope that in the adjuvant setting, you would improve outcomes and potentially cure more patients in this setting.
Very good, thank you. And then there's also, I'm hoping you can talk to us about this, a 3-factor model to predict response to atezolizumab for metastatic urothelial cancer. So what is there to report about that?
Right, so we have discovered a 3-factor model in the Dana-Farber data set. Was a small data set of around 65 to 70 patients in which we looked at patients who got a checkpoint inhibitor, PD-1 or PD-L1 inhibitor. This was either first line or in the post-platinum setting, so any line. And we looked at multiple factors to predict regression of tumors on the PD-1, PD-L1 inhibitor. And we found that 3 factors were significant: tumor mutation burden, neutrophil lymphocyte ratio, and visceral sites of metastases. And in fact, if patients had all of these factors, it very nicely predicted whether the tumors regressed or not with a very high C index of 0.90. So we went about to now validate this model. So we looked at the atezolizumab study, the IMvigor210 trial, which looked at atezolizumab in the first line setting in cisplatin ineligible patients or in the post-platinum setting. So we took patients where we had tumor mutation burden and all of these variables, the neutrophil lymphocyte ratio and the sites of metastases, and we did validate the model. So these 3 factors that we found discovered earlier to be significant for predicting regression now also predict response in this clinical trial, prospective trial setting. The C index was fairly robust in the 0.75 range, and we are very excited that this could be a model that could really help us select patients or not select patients for a PD-1 or PD-L1 inhibition. That would improve the cost efficacy of this drug and the therapeutic index of this drug.
That sounds really interesting. Thank you so much.
Thank you.
Looking ahead now, it's been a really exciting few years in bladder cancer. There's been a lot of interesting advances. Where do you think we're headed now for the foreseeable future?
Right, so there have been lots of advances in the past year. As you know, back in May of 2019, we had approval of erdafitinib, a potent specific FGFR inhibitor for patients in the post-platinum setting with metastatic disease with FGFR3, FGFR2 genomic alterations. And then later in the year, in December, came the approval of enfortumab vedotin, an antibody-drug conjugate targeting Nectin-4 in post-platinum and PD-1, PD-L1 inhibitor-exposed patients. And then later came the approval of pembrolizumab in non-muscle invasive bladder cancer, but BCG unresponsive space. So that approval came in early January of this year, 2020. We also have a press release of a positive phase 3 trial with avelumab, that's a PD-L1 inhibitor, in the switch maintenance space. So post-platinum patients with responding or stable disease had a prolongation of survival with immediately switching to avelumab versus observation. So we still await the full report of that study. We also, I would mention, disappointingly have had one negative study, which is the adjuvant atezolizumab study in patients with high-risk muscle-invasive bladder cancer that got adjuvant atezolizumab postoperatively. That study was unfortunately negative. So we still wait for these data, but it's exciting that we have so many more new drugs. And looking forward, I think that the main studies that we look forward to are the frontline studies combining platinum-based chemotherapy with a PD-1, PD-L1 inhibitor. There's also studies that are combining double checkpoint inhibition, CTLA-4 and PD-1, PD-L1 inhibition that are awaited. So all of these might change the landscape. Not only that, enfortumab vedotin is being combined with multiple, in the first-line setting with the current standards of care. And we also await the phase 3 confirmatory trial of enfortumab vedotin. And if that's not enough, we also have other drugs in the pipeline, including sacituzumab govitecan, which is yet another antibody-drug conjugate that targets a different antigen, TROP2, using a different payload, which is an irinotecan metabolite. So all of these drugs are hovering in the background. So I think we have a very exciting future to look forward to.
Definitely. Thank you so much for sharing all of this, Dr. Sonpavde. It's been a really great time with you.
Thank you.